pharmaceutical, and medical device research. Steve Brozak has specific expertise and interest in human stem cell therapies, biothreat countermeasures, and viruses such as highly pathogenic influenza, Marsburg, and Ebola. Steve has published widely and has been frequently interviewed by mainstream media. He is a retired lieutenant colonel in the US Marine Corps, having served in Europe, the Middle East, Asia, and the Caribbean. He is a graduate of Columbia College and Columbia Business School. And Steve has received a Doctor of Medical Humanities from Drew University. Steve, the floor is yours.
Well, thank you, Dame Sackler, for this opportunity to speak. Thank you, Noel, and thank you to the Foreign Policy Association for this window and allowing me to answer some questions and make some statements around SARS-CoV-2, the coronavirus. With that, I will jump into the presentation. This slide has changed over the last week, and that a statement of concern has taken it over, and that is one of irrational exuberance, which I'm sure a number of listeners and viewers can look at and understand applied to the 1996 stock market bubble concerning internet stocks. But the euphoria is something that really has to be challenged, because right now is probably one of the most critical times we're facing in dealing with this pandemic. And starting with that, I want to directly address SARS-CoV-2. Not looking to make anyone a virologist, and candidly myself not being one either, but having spent a great deal of time with highly pathogenic problematic diseases, to include H5N1, H1N1, Ebola, Marburg, and the rest. This virus is not the flu. We have a picture here showing the overall spike patterns that give it the corona type effect, which is why they call it a coronavirus. But versus influenza, which unfortunately a number of people presented this as being just a bad case of flu, it is not. It is completely different in many, many ways that are critically important. What I hope to do is explain to you what are the similarities in terms of course, it is a virus, but also what are the issues around what type of virus this really is, and the fact that we have seen this type of virus before. The next slide I go to is one that used to be more important, but I still keep it in. The differences between bacterium and viruses. A lot of people, up until very recently, were always under the impression that you could provide antibiotics to help with viruses. And candidly, it is not just problematic, it is actually very harmful. And at the end of the day, what we see with this virus is that it does one and only one thing. It lives to replicate. And anything that gets in its way, it tries to figure a way around it. The other part of this virus is that we are right now as good a host. In other words, we are the perfect partner for this virus, and it looks to do nothing but go from person to person as much as possible. Now, there are obviously other cases of humans to other animals, but right now we are still the best receptacle for it. And that is something that we really have to consider in everything that takes place. The other part is, how do we start to look at data points around this virus? What are the significant issues that we should be focused on? I'm sure everyone is familiar with Johns Hopkins and the wonderful job they've done in presenting data. This is about a week old. However, there are issues around this that I really do want to address. The first one is, even though the red glaring signs of infection are there, we see signs that are black and that give us a pause as to whether or not people are infected there or whether we have issues around that. We don't. The issue and the problem is that we don't understand, we don't have a good grasp of distribution of disease. And it's something that we really have to carefully consider in being able to fight this disease. In the areas of Africa, there simply isn't reporting. In areas of Asia, There is reporting, but it is ad hoc. And even in the United States, as we'll see in the next slide, we have issues around reporting. I don't know if everyone can make this out, but for instance, with the top right-hand slide, we see something that unfortunately should be self-evident in the form of death, but you see gaps in Florida reporting on deaths, and you see spikes in areas where there's a question mark. When we don't even have total transparency in this type of, candidly, self-evident reporting, we have issues. And the facts are that we need the data today more than ever before. And one of the things that is striking is The Atlantic, a magazine, has, from the very beginning of COVID, its journalists and its volunteers have gone out there and provided us with real-time data as to how information on deaths, infections have taken place around the world. And they just a week ago announced that they were going to suspend this activity. I would challenge anyone that right now is the time that we need to understand COVID more than ever before, and that we need the best data that we can possibly get to deal with it into the future. Now, the past is a good indicator of what has happened, or what will happen, of course, of what has happened in the past events. But what we're now looking at is, how does this affect what we're looking at today and into the future? So when I say that this is not the first time we have been struck by a coronavirus, there is a documented situation that took place not in 1918, but in 1889, a pandemic. And at first, there was much documentation suggesting that it might have been an influenza pandemic. But two research groups, one out of Belgium and the other one out of the Nordic countries, picked up anomalies that can only be explained by a coronavirus pandemic. Those were, in the case of Belgium, and they were able to find patterns of coronavirus infection doing what they call seroarchaeology that went back from drawing blood samples in the 1960s of patients that had been infected with a common coronavirus antibody. And at the end of that, they were able to go back and figure out that by replication differences, every time the virus would replicate in another person, you would see slight changes. Drawing back using that data, they were able to go back to 1889, which obviously was the documented start of this Russian or Asiatic pandemic. They also started to document other issues around mortality, but the convincing part obviously was the seroarchaeology, which was then confirmed in the Nordic countries by a couple of different groups that went out there and started to document the case studies, specifically everything that they had printed, whether it be hospital records, birth, death records, and even newspapers had been digitalized to the point where they were able to pick up the common phenomenon that we see today. The central nervous system issues that we talk about, and that I'll talk about a little bit later, but right now it's important to remember the loss of smell, the loss of taste. These are issues that affect the central nervous system. They were also well documented there, and they also provided a window into understanding how prevalent it was, and also the mortality rates and actual waves that took place. So in thinking about this into the future, we have to think about, well, is this a short-term phenomenon, which obviously initially people wrote extensively about, and how close this was to flu, when it's simply not the case. Another example, what must we relearn? We are starting to see documentation of mothers passing vaccination antibodies into their infants that are born, that are able, you can actually see the titer levels of these antibodies. One issue that was documented in 2013 was a statistical study that looked at mortality for the 1918 pandemic, that, as you can see, that spike there was in 28-year-olds. This paralleled an unfortunate death rate that was attributable to prior exposure to another virus in utero, and specifically in this case, the coronavirus of 1898. And at 1889. And at that point, the researchers started to postulate that the infants that became adults, their bodies were triggered to look at a different type of immune response. These are issues that we're only starting to recognize right now. And this is where the critical understanding of data, additional data, more data is so critically important. Again, this is real time. Yesterday, Nature published this particular piece that I'm drawing a document from, and it's specific to the description of what they call the long hauler syndrome, which frankly is still being discussed in terms of what are the particulars around it. Why is it caused? Why do some people that are asymptomatic express it much, much later after really no reason to? And how do you deal with it? These are issues that we really do need to understand. And candidly, until we do, we're always going to be playing catch up. Now, before anyone starts, I want to put this disclaimer in. Vaccines have saved more lives than all other therapeutics combined. There is no equivocation here. Going back to this diagram here in 1796 showing crude and rudimentary vaccination plans dealing with cowpox, it can easily be said that we cannot denigrate or we cannot distrust anything dealing with vaccines. However, vaccines are not the perfect answer. As a matter of fact, we have problems here that I do need to discuss and that are critical to understand. In something as simple as distribution, the vials around what we deal with the different vaccines need to be of a special type where we're just simply in shortage of them. People know about the constraints around temperature and everything around that, but we're now all of a sudden starting to see issues in distribution from, we literally had to buy an additional 5 million needles from the Chinese just to get our vaccination program underway. These are critical issues that we really do need to understand and deal with in a realistic fashion. And again, in dealing with just the AstraZeneca data that was just presented and the NIH or the NIAID's comments around data around that, we need to understand that better. And we need to look at what are some of the solutions that we may want to think about. One of the other weaknesses, it doesn't unfortunately take much reading to find out that there's a big question mark around trust, or I should say distrust of vaccinations. A vaccine isn't just a therapeutic, it's a social contract. And in order for it to work effectively, you've got to have a significant percentage of the population inoculated, not just here, but globally. Whenever you have shortcomings, whether they be due to simple manufacturing constraints, distribution constraints, or even public acceptance hesitancy, it puts the strategy at risk. And right now, we are at a crucial point as to whether or not we can effectively execute on this strategy. Additionally, and specifically with the coronavirus, as of last week, according to this diagram, we are looking at variants now express themselves more in New York City by 51% than the original wild type to which the vaccine was designed. This means that at best, you're not going to see complete coverage given variants and variant exposure, which also leads us to another question as to what are some of the issues that we face. In the past, variants have typically happened because you've had significant swaths of unvaccinated populations, and you've had treatment-naive patients expressing variants and building them up. In this case now, with a wide number of people that have immune issues, either impartial immune systems or complete absence of immune systems, they are literally people around that can act as petri dishes in developing multiple variants and doing something that would have normally taken literally perhaps even years down to weeks and days. And this is something that was not contemplated in the beginning. So at the end of the day, we now have to think about how do we go out there and deal with the exposure to these new variants, to these new issues that we're talking about into the future. And this is where I bring the idea of therapeutics. One of the particulars here is the fear. Obviously, people fear getting the disease, but more than that, they fear having significant negative outcomes, to include death. And this is where we have to understand why this is not flu. This is a chart, and I'll pull no punches here. We focused on a strategy of immune response. how to go out there and shut down the immune response, which in this particular case is called the lectin pathway. This is the immune response that you're born with. And the idea was to be able to find therapeutics that could effectively stop an inflammation that took place. And why is this important? Well, the damage is not caused in the conventional sense that most people that are expecting influenza. The damage is caused by a far more pervasive approach. And this next slide demonstrates exactly what I'm talking about. Inside you have a picture on the top screen, you have a picture of a vessel. And within that vessel, you have the blood that circulates through the vessel. Looking at it, on the inner wall of the vessel, you have what they call the smooth cells or endothelial cells. These are cells that provide for the easy passage of blood. What happens with the triggering of this attack via COVID is called a microvascular attack, and it causes a coagulopathy, or in simplified terms, a clot. These clots can develop throughout the body. They can develop in the lungs. They can develop in the heart. They can even develop in the extremities. When you've heard of people that have had issues around their arms and legs and unfortunate amputations. The loss of smell and taste are issues where you see clotting in the central nervous system. Usually it resolves fairly quickly, but unfortunately, in some cases, the damage is permanent. And again, this is where it differs completely from influenza, where it's not just limited to the lungs, and it's not just something where if you can get by, you won't have damage, or eventually the damage will be irreparable. In some cases, unfortunately, we're just still starting to get around it. Now, what does this mean? Well, it means that in thinking about this and preparing for what we need to do, the idea was we would need to figure out about how to do detection and then contain and respond using things like therapeutics if we weren't going to be effective in a vaccination program. But what we're now seeing in places like Brittany, we're seeing detection evading coronavirus, where they cannot be picked up by conventional PCR. And this is something where data and the understanding of real-time information becomes critically important, obviously for a vaccine strategy, but critically for a detection and a therapeutic strategy as well. What are some of the other issues we need to contend with? We're tired. It's a simple fact. You're seeing a picture of the Sturgis motorcycle rally, but these types of events add nothing but fuel to the fire of spread. And we now need to consider that, yes, we have a vaccine policy that's in place, and it is proceeding. However, it's got to be considered that this is the most difficult time because we have to still contain the virus using conventional masking and social distancing. Another picture of an event just right here in New York City that causes us more concern as to what can happen next. And I'm sure everyone wants to say that they're off to Disneyland that's just reopened. But again, these are venues that lend themselves uniquely to the spread. And at the end of the day, we also have to consider that whatever happens in one part of the United States is obviously going to affect another. And as we can see with the states in gray here, Florida, Texas, and even Mississippi, these are now states that really have no restrictions. They have no issues. And with spring break taking place, this is obviously a super spreader event in the happening. And unfortunately, you can calculate the number of days until you start to see mortality rates increasing in other states external of Florida. What does this come down to? Well, one of the solutions, one of the things that we need to consider are how do we go out there and effectively make sure that there's a universal and a different way of approaching this. Last week, the Rockefeller Foundation here in New York City made an announcement concerning a pandemic prevention institute. The idea would be that we now have to go over different national agendas and obviously geographic restrictions and think about how we're going to go out there and how we're going to position the world to be able to deal with the coronavirus and the issues it presents. And in the Nature piece that was on just on Friday, it describes Dr. Rick Bright, who was the original head of BARDA, and the approach that he took to dealing with the pandemic and going out there and understanding that data and science were the critical parts, and that we needed a global perspective and global partnering to be able to deal with it. Which brings me back to where we started, which was the FPA. The FPA's legacy of having started after World War I, quite literally after the last pandemic, is something we should think about as far as how do we go out there and combine? How do we go out there and form partnerships? How do we go out there and effectively mine for data and questions specific in terms of what the coronavirus does, and also general in terms of how do we go out there and ensure that we have enough manufacturing, resourcing, and the proverbial last mile to go out there with therapeutics and vaccines into the future. And with that, I'm happy to answer any questions.